Let's switch gears a little bit. Roy, I'm going to ask you to kind of briefly talk about ALK related disease. And we also saw some data at ASCO with another second generation ALK inhibitor, Alectinib, in this population. Of course, we know we have crizotinib and ceritinib out there now, but what are your thoughts around this new data in Alectinib?
Well, it's as we talked about, you know, the promise of these kinase inhibitors is the response rates, which are high, and the challenge, of course, is that most patients become resistant. And of course, we have the several drugs in class now, crizotinib and ceritinib, you know, for those who are becoming resistant. Certainly, Alectinib is another example of a drug. I was quite impressive activity, you know, in the refractory setting. So certainly, it gives us a number of choices. I guess we're going to really need to sort of figure out which mutations respond best to which drug, and my sense is that that's still evolving. But certainly the fact that there are now second generation and soon to be third generation agents. The other thing to look at with all these agents is the toxicity profile. Like with everything else, these agents are given for long periods of time. So one has to look at, you know, the most specific, I guess you would say, kinase inhibitor to have the least, you know, rash and diarrhea. So it's great that there are data now for multiple agents in this class.
Yeah, and it's, you know, we've used Alectinib a fair amount at our center, and I must say it's a well-tolerated drug agent in this population with a good amount of activity. The other impressive thing, and what we deal with all the time in the ALK population, is brain disease. And there was some nice data with regard to response in the brain. That's a major issue for us in this setting.
Well, and the responses in the brain seem to parallel the responses outside of the brain, and also they seem to be nearly as durable.
Right.
I think crizotinib is going to be an easier drug to beat in the first line with one of these new drugs. Yeah. Right? Crizotinib isn't the perfect ALK inhibitor. It has a lot of these brain failures. It was the first-in-class drug, but I think it'll be easier to beat crizotinib than it will be to beat erlotinib, gefitinib, afatinib for first-line EGFR. And Alectinib certainly has a toxicity profile that I find my patients have an easier time with than ceritinib, where, you know, it can be hard to manage over, again, as you described, over months and months and months of diarrhea and anorexia. Ceritinib can be tough on patients.
Absolutely.
And we mentioned in the EGFR space, I believe the ALEX trial is fairly close to finishing its accrual, which compares in the first-line setting crizotinib to Alectinib. And I tend to agree with you. I think that's a lower bar to get over relative to the EGFR space in that particular setting.
If only you can prevent the brain metastases. That in its own is such a big problem. And in my young ALK patients, I'm reaching for ceritinib or Alectinib second line instead of whole brain radiation.
Yes.
Trying to prevent that morbid intervention and prolong their time.
How do you follow your patients for brain disease?
We do a lot of brain MRIs.
Yeah.
But I do it after it's been, I don't do surveillance brain MRIs without brain mets being identified.
Yeah.
But in, you know, I have patients who have very little systemic disease, and I'm primarily working with a neuro-oncologist on ceritinib or on Alectinib to follow the brain metastases.
Do you have a size that makes you concerned? You know, if the brain lesions are more than a certain size, do you then use Gamma knife or some other procedure?
We certainly do. Or, you know, when do you bite the bullet and go for whole brain radiation? We're learning about this. You know, we're really creating a patient population that we're learning about as we go. That's been created because of ALK and crizotinib.
Yeah, the data at ASCO, I think, with regard to the brain responses in lieu of radiation was, I think, very helpful in day-to-day practice. It's a prominent issue. Many times, since we're frequently doing MRIs, we find very small lesions that are asymptomatic, don't have a lot of edema associated with them, and having the option of switching to these second-generation agents, I think, is a real advantage in the ability to delay radiotherapy for some time. Maybe not forever, but for some time, I think it's important in this population.
Agreed.